South Africa is a developing country with an exceptional past. Our legacy is that of a prolonged freedom struggle characterized by political violence and state-mandated oppression. At its core, the conflict has largely resided, yet alarmingly high levels of interpersonal violence remain, fueled by rapid urbanization and continued socioeconomic disparities. News of violent crime frequently makes headlines in South Africa, and Johannesburg is now regarded as one of the most dangerous cities in the world. This is a list that is compiled by the Mexican Council for Justice. They publish a list every year with the top 50 most dangerous cities in the world based on their homicide and murder rate. And aside from the South American countries with their drug trafficking, South Africa is the only other country with entries into the top 20, with no fewer than 5 countries appearing in the top 20 list, as you can see below here. Despite this, we still have no national trauma database to substantiate this information. So why do we need a trauma database? Trauma registries have evolved with the quality assurance movement, which borrowed heavily from the Japanese industrial system, where the management philosophy is based on statistical process control. In their model, rigorous statistical methods are used to study flow processes, ultimately leading to quality improvement, and this is how the Japanese economy has emerged as a world leader. If we apply this to trauma, continuous, measurable improvement of care given to an injured patient is the goal of any quality assurance system, and a trauma registry would allow for this through continuous monitoring of the process of injury care. If we look at models used in other countries, the USA probably has the most widely adapted model, which was initiated by surgeons after reviewing their medical services offered to trauma patients. And it now works in a system where hospital emergency rooms and trauma centers are participants and submit data to the data bank. And in return, they receive access to reports analyzing their data and their surgical outcomes, as well as the country in general. And in this way, benefits everyone. If we look at South Africa and what systems we use, a move has been made by individual hospitals to initiate and mature electronic-based systems to allow for quick and accurate data capturing. Major trauma systems in KZN, in the Western Cape and Pietermaritzburg have already done this. In Johannesburg, however, trauma numbers are amongst the highest, but we have little data published to substantiate this, and this is the basis of my study. It is titled A Long Walk to Freedom, the Epidemiology of Penetrating Trauma in South Africa, an analysis of 4,697 patients over a 6-year period at the Chris Hani Baragwanath Hospital. The objectives were 4. Firstly, to identify the at-risk demographics, so the age, the sex, and the race of the patients, identify the times at which these injuries are most likely to occur, to identify specific areas in Johannesburg where incidents are most likely to occur, and assess the anatomical areas that are affected by penetrating trauma. It is a retrospective study in design, with the population being those within the drainage area of the Chris Hani Baragwanath Academic Hospital, which is the third largest hospital in the world. They received direct referrals as well as referrals from outside hospitals. The participants are all P1 patients who were admitted to this hospital resus area for a 6-year period, 2011 to 2016, and the data was captured in the form of Medibank forms, which is a paper-based system, including information like patient demographics, the mechanism of injury, the time of presentation, the injury severity score, as well as the anatomical region of injury. Data was analyzed using STATA14 software for statistical analysis. So what are the results? So the first part was looking at patient demographics. And of this, we found that young males were overwhelmingly the majority at 92%, with the median age being only 29 years old. The major race affected was Black Africans, which we can expect as that is the population that is served in this area. Now, considering that young males are the most important and productive population group with respect to educational training and workforce, it follows that this would have grave consequences for the national economy. The next thing we looked at was the time distribution. So we found that the weekends, with a Sunday followed very closely by a Saturday is when it mostly occurred, and between the time period 6 p.m. and the following morning at 6 a.m. Mondays and Fridays were also the busiest weekdays. And this is in keeping with what one would expect, as our trauma burden is often associated with alcohol use and assault or interpersonal violence, and this generally occurs after working hours or on weekends or holidays. The last weekends of the month tend to have the highest statistics if you look at the time distribution, as well as mid-month weekends, which is also in keeping with what we'd expect, as people are mostly paid their salary around the 25th of the month and are thus more financially able to engage in social activities and purchase liquor during that subsequent period. If we look at the injury mechanism, the majority was stabbings at 71.8%, gunshot incidents was around 26.2%, and handguns and shotguns were identified as the commonest weapons used in this instant. If we look at the body areas affected, the commonest is the thorax at 44%. A hemothorax is the most likely consequence of this at more than a 50% incidence, and a pneumothorax the second commonest. A cardiac injury is associatively found in 4.4% of patients, and the abdomen was the second most commonly affected area. Now, if we look at the geographic distribution of injuries, this is where it gets really interesting. The highest rates of penetrating trauma occurred in Region D, which accounts for just over 50% of all trauma. And the highest associated areas was Orlando, Freedom Park, Diepkloof, Meadowlands, and Protea. And these are all the areas of the most long-established townships, where large informal settlements make up the majority of the housing. Now, just in order to explain this a bit better, we're going to look at a map of the city of Johannesburg. So it's divided into regions A to F, and the region highlighted here, D, is the area which is serviced by this hospital that we're looking at in this study. It has a population exceeding 2 million and faces major challenges as a result of lack of urban planning, high rates of poverty, and social issues thereof. And this area encompasses the township of Soweto, of which Orlando was the first township established. If we look at where all these areas are in association to the hospital, you can see that the hospital is marked in red here, and the black markers are for the 10 highest incidence areas around it. So they're all in quite close proximity and should have quite good access to the hospital at this point. We then look at where the police stations are in relation to these hotspots. The police stations are marked with the P's in red. There are a large number of police stations in the vicinity of these areas, but that doesn't appear to impede the high rates of crime and interpersonal violence that occurs here. So there was actually a crime response app developed called Namola with more than 500,000 users, and it works like the 911 emergency number in the USA. You can call them and emergency services can be reached via this. And according to their data, the commonest single type of request is for an ambulance service in Soweto. And the citizens in this area have been requesting assistance more than any other area, suggesting there is a community faction that is reaching out for help. Where the police services are unable to respond adequately to the community needs, or they are overwhelmed with inadequate numbers, is another discussion that we could have about it. If we further look at it in terms of alcohol, as we know that is often a contributing factor in our population, there are in excess of 50 legal alcohol distributors, comprising of township taverns, shebeens, pubs, and liquor stores, all legal within a 10-kilometer radius of these 10 areas around the hospital, as you can see are marked in blue. In reality, we know that this number is likely higher when one considers the illicit informal alcohol sales that is often found in informal settlements. So this is quite alarming. So what does all of this mean? Why do we still struggle with so much of violence and abuse in this country? Is it the social inequalities? Is it the poverty? Are we seeing the repercussions of our past? And is trauma intergenerationally transmissible through hormonal and epigenetic processes, as some studies have shown us? These results, I believe, raise far more questions than it answers. In conclusion, we know that penetrating trauma is inherently linked to alcohol abuse in South Africa. It primarily affects its young, economic, working-class citizens. And this study has merely proven or shown some intriguing insight into the burden, structure, and challenges of the trauma system in Johannesburg that need to be addressed. In South Africa, I believe an entire systems change must be undertaken. where key issues in society, including mental health, social factors, and economic disparities, need to be appropriately addressed. And healthcare workers can initiate this, starting with a national trauma database. Thank you.